physician at AIMS and received the honor from ex-president late Dr. APJ Abdul Kalam. We also have Dr. Vibhas Gupta with us from GE, who represents Medical Affairs. Dr. Vibhas will be moderating the Q&A session along with Dr. Shetty, and he will take up the discussions. Before I hand over this stage to our speaker, few pointers I would like to convey here. We will be running a live Q&A session, and as you can see below the screen, there is a Q&A chat box wherein you can post your questions. All of you are requested to utilize this session and take the advantage by asking the questions with our speaker. With that, I would hand over the stage to Dr. Shetty.
Hi everyone, and thank you Rohit, thank you Vibhas for carrying over this session. So we were planning this program for a long time. Initially we wanted to do it live with all of you in stadium. Then because of COVID we couldn't do it, but it has given us a good opportunity for us to do it through the net now, and probably we will be able to reach a larger audience, and I'm happy about that. At outset, I would like to thank GE for giving the technology support, and we have been working together for this program for nearly a year now. So this is, as you realize, that cath is something which we keep discussing as cardiologists. This is something which is basically discussed, and this is extremely important for your exam, because they're going to ask a lot of questions. And with now, I think now you're likely to have OSCE sessions. Now OSCE probably is nothing more than a prolonged or a little longer spotter. Always DNB exam used to have spotters, and they used to be given, I think, 2 marks and 20 spotters, and it would be for 40 marks. And now the same thing, probably each question is going to be 5 marks, and I think it's altogether it's around 200 marks. So that means this topic which we are going to discuss becomes extremely important. It's very likely they're going to put some of these data, and it's very likely that they're going to discuss little more in detail so that you're fully aware of the whole system. So what we thought is we will divide this topic into the plan is to do 3 such sessions. One today, 3 consecutive Fridays. So today is the first one. We're going to have one on probably 7th of August. That will be the next Friday, and one on 14th August. The 3 sessions. First session, which is today, I'm going to discuss extremely basic stuff with how to do oximetry, and today it will be only interpretation of oximetry and pressure data. That means we are going to discuss number, the number based question. I'm sure in your OSCE or whatever we call it now, you would have 4 or 5 questions based on this. The next class, that is the next Friday, we're going to discuss the tracings. How it's not the number, it's the tracing. How will a LV, RV tracing look? How will the pullback look? And then I'm going to show you some cases. And the third one is going to be only on angiogram. First to, like LV angio, RV angio, what are the different angios which you should know. So I think together all this will be little comprehensive, and you would be covering 3 aspects of the cath interpretation. Today's class, again, I've divided into 2 parts. Probably each of them would be around 40-45 minutes. We'll take a break in between. The first is going to be theory, how to take sample, where to take sample, what are the errors you are likely to encounter during sample. I agree that this could be a little bit boring, but this is something which you need. The second half of today's talk, we have around 20-22 examples with the data, and slowly we are going to discuss with you. Unfortunately, I think we are not able to have a direct communication. So whenever I give you time, make sure you type your options, and Dr. Gupta will pass it on to us, and we will discuss. Also, whatever queries you have, feel free to put it in the group. We'll be I'll try to answer this. So going to interpretation of hemodynamics, oximetry, and pressure data. So let's see the the first few slides, which is theory. So as I told, one is basic, second is interpretation. You should realize that whenever we learn anything, it could be anything. It could be a new language, new skill, could be ECG, could be echo, could be cath. We should understand that all these, they have their own alphabets. Like when you learn Hindi, you'll have IE, English, ABCD. The first thing is to, understand those alphabets. So understand the rules. Typically, rule of a game is not changeable. You need to understand the rule. You need to master. You can't change the rules in almost all games. So you need to master the rules. So first, we are going to discuss the rule. Second is interpretation. Like, for example, cat in one language, you can always understand what, once you know the name in different languages, you know what it is. So here, you know about VSD, you know about ASD. But the way we look at ESD in, say, ECG, clinical examination, echo and cath is different, although it is the same ECG, the same VSD. So that is what we are trying to, understand. So sometimes you cannot extend your knowledge, but understand the basics. And then you will be able to do, once you know that this particular thing in VSD means this, then your basic knowledge of VSD will kick in and you will be able to understand it better. Okay. Now let's do the sample collection. That sample collection is utmost important. So we need to understand how to collect these samples, where to collect this sample, and how to, what to look for in the sample. So oxygen consumption, this is again, it's more theory, because you should know that most formulas, has VO2, that is oxygen requirement, VO2. There are machines which can do that, and now these machines are available more easily because we use VO2 for even transplant assessment, so it is easy. But classically, measurement of oxygen consumption is based on Douglas bag method or polographic method or assumed value, which is based on a chart. Where do we measure pressure? We need to measure in right-sided chambers, which could be RA, RV, PA and PCWP, left-sided, and any other abnormal changer, we need to measure that. Now, what are the catheter use? This is extremely basic, but it's very important that we go through it because we understand. Typically, end hole catheters are used, which could be balloon flotation or non-balloon flotation. Schwann-Ganz is a very classical exam. Again, in, I don't think so you'll have it this time because most of the time the exam could be contactless. But if you have a contact exam, there is a session where they're going to put different catheters and they're going to ask you. Again, as we have been discussing in many other previous classes, the catheter identification is considered basic. So you could use a catheter like Schwann-Ganz, which is end hole, or if there are catheters with a terminal side holes, you could use them also. Whereas when we discuss angio or cath, which will be in the third class, we will analyze more on catheters because there you're going to look at catheter. Today this is enough. It's done under fluoroscopy and chamber is identified by pressure trace. Now, when do you take a oximetry run? This is something which will be asked to you most of the time. Baseline state is very important. There has to be a steady state. A very agitated side or a too over sedated child may not be very ideal. So you need a very baseline date, and all the data should be done within 7 minutes. Otherwise, the baseline data will be altered. So remember that 7 minutes, which is very important. Withdrawal is preferred. That means imagine you're taken SVC sample, you're taken IVC, you're taken RA, but you're not able to enter RV, or you have entered RV, you're not able to go to PA. So this becomes extremely difficult because if you're not able to go for whatever reason, it becomes difficult. So it's advised that you go to PA, wedge it, and then start taking sample from behind. So withdrawal, pressure and saturations are better. So when you go in, you don't have to take it. When you come back, that is when you take this. Next, I will, the next class when you do pressure, I will describe how to identify whether the catheter is in PCWP, whether it is wedge and all those criteria. But today the most important is how to acquire the data. It's very important. Withdrawal is better. It's not a must. You could also do onward, but since you cannot predict whether you will be able to enter PA all the time, the withdrawal becomes very important. If there is a VPC or some arrhythmia, some run like in RV, you know, sometime when you keep the catheter and there is lot of VPC, in which case you may have to wait till it is comfortable and then only measure the catheter. When you're doing angiogram, angio should be later, because angio itself can change the hemodynamic, especially when the LV is not fine and when there is a lot of LV dysfunction. The addition of extra dye, which is typically a depressant for ventricular function, could alter. So it's advised that you take your pressures right and you take your samples before you do the angiogram. Do not over heparinize, because it's sodium and heparin and the values get altered. Remove all bubble before capping. You know how it is done. I'm sure most of you understand how it is done. So typically whenever you remove a sample, especially in a child, you don't want to remove too much. So you need to withdraw. First 2 cc is discarded and then you take the sample. Typically around 0.5 cc is what you need. But if there is an air bubble, make sure you remove that air bubble and then cap as soon as possible. Immediate analysis is ideal, as soon as possible. This is difficult because the pulse oximeter, the machine which does the oximeter, which was used for a long time, is not easily available. Nowadays we have to depend on the ABG machines to do that, which is not ideal. It would have been extremely better to do on the saturation, because in ABG the saturation is more derived. It's not a direct saturation, whereas those saturation machines which were available earlier, they actually do the saturation well. If it is delayed, you have to cool it in ice, typically those bags, and you label it properly and keep the sample. At least from each side, remove 2 samples and label it properly so that the lab error gets minimized, and ice cooling, but not ideal. Ideal is to have it in lab and do it. These things were very easy. When we were doing DM, it was easy because the lab would always have this machine and lots of casts are done. But nowadays it is difficult to find this ideal situation. Now, which is a better syringe? Glass syringe is a gold standard, it's better, but typically just not available now. So we need to use the plastic syringe, but need to analyze faster. WBC metabolism, high platelet count can alter, and as much as possible, do not use ABG machine because it's calculated from PO2, but use the oximetry. But as I clearly mentioned, it is difficult. In our own lab, I'm trying to get that pulse oximeter. It's just not manufactured now any longer. So we are also now depending on the ABG machine to do the same thing. So what are the guidelines that I'm sure I'll share the slides with you, but blood sample in multiple sites immediately. Saturation data is very important than O2 content data, which will come to later. Comparison of the mean of all values preferable. We'll come to that in a little while. And, exercise, especially the bicycle exercise, can be used. Now, how do we detect shunt? How do we quantify it? And how do we estimate the pressures as well as resistance? Shunt detection is, again, there are many methods to do it, and basically, as you realize, they typically use fixed principle, but other methods. This is something which you should do. I think it's no longer done anywhere. Cardiac output can be used using 2-3 method, but this can still be your question when they ask you in examination. One is endocycline dye or green dye method. It's a dye method. So the principle is still the same. You inject the dye and look for the peak of the appearance of the dye in first pass, and then do the calculation. Just remember this name, that should do. It is more sensitive than oximetry, but it's no longer used now. The other method which is used is obviously a thermodilution method, which is useful to measure cardiac output, not so much for the shunt, but in a stable patient cardiac output, thermodilution method is used, but basic principle of most method remains the same. Next, coming to the one more very basic thing, the pressure, because this is what we are going to analyze. Today we are going to look at the saturation and we are going to look at the pressure. Zeroing is extremely important, and my advice is if you are doing cath, make sure you zero it multiple times. Even in between a procedure, if it is a long procedure, it's very important for you to intermittently zero both your lines, and be careful about technical error in zeroing. You may have to, typically most labs will have two pressure transducer, and you may have to zero both of them at the same time. PCWP measurement and withdrawal gradient, which obviously is which we are going to discuss in the next class. When you do that withdrawal gradient, multi-hole like pigtail are not very useful when you want to do withdrawal. It's the end hole catheter which is important for withdrawal. This is the slide which is showing how the importance of zero. You should understand the 0-9. If the patient is in the position where is the zero also where is, these are extremely sensitive, because if you don't get the pressure right, you're going to have a lot of mistake in your further analysis, and it is possible that the operability itself may be in question. So make sure you zero it well. This is what are the sites where we do sampling. Just look at this graph. It is extensive. You might need 14 samples or maybe more sometime, but it's not possible to do all of them. But it's very important to know that multiple sampling is needed. Okay, and there is a reason for that. Look at this, the sequence clearly mentioning it's a withdrawal sampling. That means you start from the PA, start from the wedge, but you don't have to sample the wedge. LPA, RPA and MPA, try to take all of them. Then RV, there are 3. You should know exactly this site: RVOT, mid cavity and RV inlet. Remember, ventricles are tripartite. That means they have 3 components. So one will be inlet, one will be mid and one will be outflow. RA, extremely important. Again, 3 sample, high, mid and low. Very important when you do it in RA, make sure your catheter is actually facing towards outward. That means not towards the spine but on the other side. Reason being, if you face towards spine, there is interatrial septum, and if there is ASD, you could actually pick up LA sample. So it's very important you do the other way. SVC, again high and low. How do you decide high and low? It is actually where the vein joins, the azygos vein. Typically you want it above the azygos and below the azygos. Vena cava, again high and low, which is above the renal and below the renal, because renal veins are important, and you need to take 1 ventricle or 2 ventricular sample. You need to take aortic sample, ideally before and after. That means if you do it properly, you need 14 to 15 samples, and that's what you need. Sometimes you may not be able to do all of them, but remember, whatever is highlighted is a must. That means you need to have a MPA sample, you need to have RA mid and RV mid, you need to have a high SVC, not the low SVC, because RA will represent that high SVC, and you need to have IVC, high IVC, which is important. Also, you need to know the ventricle. Sometimes, if there is a cost issue, or, what happens is if you're doing it in an ABG machine, and if ABG is charged, it becomes difficult. But at least these 5 samples will be, 5 or 6 samples will be must. SVC could compensate for mixed venous, so you need SVC. RA, RV, PA will be must. LV will be must. Aorta you can avoid proximally, distally, beyond ductus is what you need. So this is the minimum number of samples you need, and maximum could be 14 or 15. Now this one. Now the very important point is what are the different, what happens in IVC and what is the mixed venous sample. IVC saturation is little higher than SVC. Now this is surprising. I mean, all of us believe SVC should have enough blood because it goes to brain and heart. But you should also remember brain, and the brain especially extracts lots of oxygen. So the venous, which is the SVC or brachycephalic vein which join, actually the saturation is lower. But IVC saturation is higher, abdominal saturation, visceral saturation is higher. Lower limb, again lower, but the IVC is higher. What is the reason for that? Kidneys. Kidneys receive 1/5 of the cardiac output. Not because they're just 250 grams, they're not big organs. So the blood flow to kidney is not to sustain its survival, but for ultrafiltration. So around 20 to 25% of cardiac output goes to kidney. But the purpose is excretion, so the extraction of the oxygen is lesser in kidney, and hence IVC blood above the renals is higher, has a higher saturation. So IVC blood, if you see, IVC blood has visceral blood, and IVC blood also has the limb bloods. Now the limb has lower saturation, but the visceral part, that is the renal part, is higher, because the rest of the viscera actually go to liver and it comes as the hepatic vein. So IVC blood below the hepatic, above the renal is one of the venous blood with the highest saturation. It could be at high as 80%. Okay, the coronary sinus on the other hand has the least venous saturation, because heart, which is an actively pumping organ, will extract much more oxygen. All of you must have realized when when you think you're going to PA or PV and you're in coronary sinus, when you aspirate the blood, it is really dark in color. So the least saturation actually comes from the coronary sinus. Okay. Now, routine oximetry run, you remember something, that cath which we do today is not blind. There was a time when, I'm sure in 70s, there used to be stories where people would examine and find a white fixed plate, do a cath and show a step up, and go for operation of a ASD, because there is a split now, because they did not have echo at that time. Hence, and there are people who have opened then closed because there was no ASD, there was some PAPVC, and they missed the whole diagnosis. But today's era, when we do have a lot of information. We have echo, we could have done a TE, you could have done a CT. So you do have a lot of information apart from just clinical examination. So today's cath is not probably like the cath which was there 20 to 25 years back. It's changed a lot. The importance of cath has come down, but there are some, today when you do a cath, you're asking questions in yourself and you're trying to answer that question. Most of the time it never a level of shame, because you know that answer. Most of the time it is a physiology. What would the RV say? Is this reversible? Is there a benefit of those in heart transplant? What will be the heart transplant? You have a very specific question. Most of the time this question is not the diagnosis. Diagnosis is made and then you do a oximetry run. So it's very important. And talk of highest is very important to rule out EMINENT and EMINENT, and representative sample should be done and need to understand the venous. Need to understand that. So a significant step up is actually an increase in oxygen content by 2 volume. So, and for when you are looking at RA, because in RA, it's a combination of SVC and IVC. And these are two very heterogeneous sample, and you can have a 65 to 75. If SVC or IVC is extremely low, that indicates low cardiac output. Like in DCM, if you typically you want both these to be around 75. If it is around 75, then it's fine. SVC and IVC. Around 75 would give a cardiac index of around 3.2 if arterial saturation is above 95, 3.2 to 3.3. But if it's too low, it is a sign of poor perfusion, like in DCMs or cardiogenic shock. You could have a very low mixed venous saturation. RA, which is a combination of this, is between 75 again. RV and PA, if there is no significant step up, they will all be almost same. Whereas PCWP or arterial wedge is typically 100. Pulmonary vein also is typically 100, 98 to 100. Okay, so we'll also come to assumption. Most of the time pulmonary vein is an assumed sample, because you can only remove it if you go to, if there is ASD and you are in LA, And then when you do that, you go to at least 2 pulmonary vein needs to be sampled. Typically, left-sided sample again mimic each other unless there is a right to left shunt. Please note the pressures also so that you understand it well. RA mean varies from 2 to 6, can be 0 sometime. When it comes to RV, we need to know the systolic and need to know the diastolic. PA again matches, usually no gradient. PAW, that is wedge, actually is a LA pressure, and although there is a phase shift, the pressure is actually LA pressure, and LA is little higher than RA and it can go up to 13. So please have these values. LV and aortic pressures match each other. But what is important also is to understand that the blood needs to go in a one direction, and it is okay. So when you do a pressure data analysis, make sure that is it normal or abnormal. So you need to have an idea of normal. The link pressure between chamber, that's very important. How are each of these chamber linked? Okay. So for example, RA mean and RV-ED, because the blood has to go, are linked, whereas RV systolic and PA systolic are linked. If there is a difference, you don't expect PA to be more than RV, maybe 2 millimeter more, 3 millimeter more, but at any condition you don't expect it to be much more. So make sure they are linked with each other. Again, PA mean is higher, slightly higher than the PAW, which is LA pressure, and LA mean should be slightly higher than LVEDP. Make sure that this chart is made. And sometime in exam, your examiner does ask you at the end of it to actually, you have a clinical case with the complex multivalvular. They will ask you to write these pressures. So when it looks at, it will tell them whether you have really understood it. So how do you do that? A BP will obviously be aortic pressure. Then if there is no AS, you will figure out the LV pressure and compare it with the EDP. You look at the pulmonary capillary wedge. If there are crepitation, then you know the LA pressure and pulmonary venous pressure is higher. A little bit crepitation, it will be 25. More than that, it will be much more. JVP gives you RA pressure, and amount of PAH will give you RV pressure and thereby PA pressure. So make sure that tomorrow, next time, whenever you present a case, take 1 more minute extra with your friends to jot down these pressures without actually measuring, because it is possible your examiner actually asks one of these. Now calculation. I know it looks boring, but this is something which you should know, especially till you finish exam, and you need to understand. So very basic, QP is flow through pulmonary vascular bed and QS is systemic blood flow. So nobody has doubts. Right to left is when there is aortic desaturation. We have a slide on that. I will come to that. And what is very important is QEP. This is one more question which people will ask you. You don't have to calculate in all cases. You have to calculate only in cases where there is bidirectional shunt. Now what's QEP? QEP is the lowest possible number you can have. It's called effective pulmonary blood flow. That means this is the systemic venous return which goes to the lung to get oxygenated. So I'm going to repeat this. It's a very important flow where it is a systemic venous return which goes to the lung to get oxygenated. Because QP, which is the pulmonary flow, is in the presence of shunt. QP has 2 components. One, systemic venous return which goes to PA. The second, the left to right shunt, the one which has come from the pulmonary venous return which goes to PA. So there are 2 components for QP. It's combination of QEP plus amount of left to right shunt. So QP is always the normal and the least number which is possible. Okay, remember it is the smallest number. And the formula for QEP, you will come, this is something which you are going. It's the effective pulmonary flow. That means amount of systemic venous return which is going to PA. Okay, so for example, look at the case of TGA. TGA almost always has high QP. Pulmonary flow is high. But most of this flow is the parallel circulation. Pulmonary venous return comes and it goes to pulmonary artery. Very few systemic venous return goes to the pulmonary artery. So TGA is a classical condition where is high QP but low QEP. So this is something which people are going to ask you. So TJ is a classical condition where the QP goes very high because there is ineffective pulmonary circulation, but the QEP is the lowest. So I hope everybody's understood QEP. That is something which is very important and something which will be asked. Now, how do we do all this calculation? Because, you know, there are 2-3 methods which we discussed, but typically when you're looking at the saturation, it's using fixed in principle. We're not here to discuss the fixed principle because that's something which we have done in first year, MBBS, with whichever book you read, Gaitan or Ganong, and nowadays there are other books like I think Shambulingam. So basic concept is flow is, if you know the oxygen consumption, then, and you know the arteriovenous difference between the oxygen, then you know the flow across any organ. It could be kidney, it could be brain, it could be heart. But when it comes to lung, there is a big advantage because you know the VO2. VO2 is the oxygen consumption. So for both QS and QP, whatever two we calculate, VO2 is fixed. Whereas if you want to do for kidney, you need to know the kidney oxygen consumption, which is very difficult to pick up. But luckily, we are not doing that. As cardiologists, our aim is to do the lung and to do the heart. Assumption here is just lung itself, the VO2 requirement, VO2 which uses is as much as the body, and whole rest of the body also uses the same VO2. Okay. Now, how do we get this VO2? We'll come to that. So VO2 is same. So for fixed principle for QP and QS is easier than what you need for brain, heart, or any other organ. So to quantify current, we need to know the oxygen consumption, which is VO2. Typically, I'll show the chart. Then we need calculation of saturation, and sometime you need the total oxygen content. Now, how do you get VO2, which is same for QP and QS, but how do you get? So the ideal way to do is using this Douglas bag, where you have control on amount of oxygen entering and amongst you can analyze the expired oxygen. So you know the flow, you know the amount. So you know typically the FiO2 of inhaled air is 0.21 or 21%. FiO2 of exhaled air could be 16 or 0.16, and you know the amount of oxygen consumed divided by body surface area, you get a VO2. That's using Douglas bag. Remember, this is just theory because you don't need to do it. There are direct methods which is called poliographic method, which can also pick up. Again, one more important name which you should remember if your examiner asks. But most of the time it's done using empirical formulas. And this is the formula which you are allowed to take to your exam. Okay. So how do we do that? We need to know body surface, and there are formulas for body surface and there are charts. So you need to know the body surface of the person. Okay. Using body surface calculator. What else you need for usually if the child is less than you could less than 3 years, then there are no charts. Charts come after 3 years. It's 125 into body surface area. If the child is more than that or person is more, then there are charts available for boys and girls, and it is up to 40 years, and anything above that you can assume that the maximum value along with heart rate. Please concentrate. Heart rate is an important determination of oxygen consumption. Sometimes what happens is when you do something, the pre-heart rate for some, this one is 80, but post oxygen, the heart rate could be 90 for some reason. Or in BMV, when we do cardiac output calculation, the pre-BMV heart rate would be different, post BMV is different. So make sure whoever is posted in cath lab has to note the heart rate also. So you need age, you need heart rate, and you need the gender. That's all you need to get the VO2. But this VO2 is actually, this will give you indexed value because VO2 is indexed in almost all cases. So you will get indexed value. You will get QP, QP indexed to body surface area or QS indexed to body surface area. Then you have, how to get so we understood the 3 components was saturation. Now, how do you get total oxygen. So, the oxygen carrying capacity of the blood is actually, we need to know the hemoglobin. So oxygen content is what you need. You need the total oxygen content both in arterial side and the venous side. It's assumed that if you are not on high flow oxygen, the amount of saturation, oxygen is predominantly carried by hemoglobin. All you need to know it is a constant hemoglobin and saturation. Books vary on this 1.34 to 1.36. I think 1.34 sounds is the best option, but there are formulas where 1.36 is used. Don't worry about that. Plus, so that means if there is 10 is the hemoglobin, saturation is say 94, so it will be 10 into 94 into 1.34. That will be the oxygen carried by the hemoglobin. But the bound oxygen, the unbound or dissolved oxygen is a very, very small amount compared to this. So that's going to be 0.03 into PaO2. That is dissolved. The problem comes most of the time PaO2 is 60 and 70 and it really doesn't matter. But if you are giving high flow oxygen, like 100% oxygen, do not neglect this component. I have an example to show that. Do not neglect this component if you are doing that. So total oxygen compared is oxygen. We see it's 1.36 here. Use 1.36. It's hemoglobin into 1.36 into 10 into oxygen saturation plus dissolved oxygen is. This is plus 0. This is total oxygen will be plus 0.03. But most cases this element dissolved is so less that you can neglect it. But do not neglect in post oxygen data. Any post oxygen, whenever you are pre-oxygen, you can neglect it. Post oxygen, do not neglect. We'll show the example where it is very important. If you neglect the dissolved oxygen in the post data, there will be up to 20% error. And that error is huge because that's the case where you're deciding whether to operate or not to operate. And this error, 20% error is huge. So make sure, take some more time, use the formula. All you have to do is along with what you are already doing, add 0.03 into partial pressure of oxygen. It could be 600 normally it is 60, 80, 100. But in a FiO2, when the FiO2 is 1, when you are giving pure oxygen, amount of dissolved oxygen could be so high that could be 0.03. Now, how do you calculate QP? Again, remember this is indexed QP. You have O2 consumption, which is VO2, which for all practical purposes comes from the table divided by pulmonary venous minus pulmonary artery. You are showing the flow across, so it is the amount of consumption of the total consumption of oxygen plus the difference between the arterial side and the venous side. But here arterial side is pulmonary vein because it's on the other side, and the venous side is pulmonary artery. The inflow side, it's outflow sides to inflow sides. Okay, so pulmonary vein is the artery here and pulmonary artery is the vein. So that's a U minus. Okay, and how do you do for systemic? You need systemic artery, which is typically aorta or femoral artery, rarely radial artery, minus mixed venous content. That's for QS. Now mixed venous varies. This is very important. If you are taking QS could be equal to cardiac output. So if you want a case, you're doing it for a DCM or a heart transplant assessment where you don't expect shunt, the best mixed venous sample again is pulmonary artery because everything mixes in pulmonary artery. Other cases, it could be prior to the shunt. If you are very sure there is no, there is no foul play, there is no multiple step ups. If you are not sure, then it could be a mixed venous, which would be either SVC alone, that's enough and sometime, but ideally it should be 3 SVC plus 1 IVC. Now, why is this 3 SVC, 1 IVC? It's calculated. It's not because SVC carries 3 times the blood. No, it doesn't. Typically, cardiac output is 50% from SVC, 50% from IVC. But it's like river flowing and saturation curve is not purely additive. It's because the SVC has 80, IVC has 80, SVC at 50. The sum won't come at 65. It won't be a midpoint simply because saturation curve is it's a sigmoid curve. It's not a simple curve. Hence, derived from the formula, it is 3 SVC plus IVC. Since SVC saturation is most important, SVC alone also can be used if you don't have IVC sample. But this is, if the patient exercises, especially if there is a leg bicycle where the patient actually is exercising and the leg muscles, now the cardiac output is increasing, then the formula is actually SVC plus IVC divided by 2. Here it will be 3 SVC plus 1 IVC divided by 4. But if the patient is exercising, this is again a theory question which could be asked. If there is a bicycle exercise which is done, then it is SVC plus IVC divided by 2. So divided by 4 is important here. Now, what are the independent of oxygen, independent of hemoglobin, independent of body surface area? We like those. That will be QP by QS will be ulta, because they are in the denominator. The ratio, because that's what we want to show, it will be opposite. So the numerator is aortic saturation minus mixed venous, which could be PA, RV, RA or SVC, IVC, depending on the level of shunt, divided by PO2 minus PaO2. That is the lung one. So imagine this is 98 and this is 68. The numerator will be 30. And imagine this is 98 and this is 88, denominator is 10. So the ratio will be QP by QS simply will be 3:1. So this could be done when you have to do things fast and especially in exam. But when you have to really do, make sure you get some data and analyze it yourself. That is very important, which can be done. So any doubts here? So the next one will be oxygen content, which is oxygen, this one example for us to do it very simply. So how do you do the oxygen content? So we know the formula. So hemoglobin, you look at this in this patient. Let's do one example so that we are not doing any mistake here. Oxygen capacity of hemoglobin is 15 into 1.36. Which is equal to 20.1 is the oxygen carrying capacity of the hemoglobin. This you need to multiply in different saturations and understand the QS, which is VO2, which is 150. And here it is what's 0.95 minus 0.65 mixed venous into, because it's in percentage, into this was the oxygen carrying capacity of the whole blood. So it becomes 2.51. And same thing in this case, there is no shunt because you don't see any step up. You realize the PV also is exactly same and there is no difference in both the values. So this is how you do. So VO2 comes to the numerator, you minus the saturation of iota minus mixed venous, and the same thing you do it in this. But if there is dissolved oxygen, this is very important. The example one where the dissolved amount of the partial pressure is 90, the oxygen carrying capacity contributed by dissolved blood is only 0.27 ml. Whereas if the PO2 becomes 600, which can easily become, if there is a high FiO2 1, then it could become 1.8. This 1.8 added to 20, with 20 which was there in the last equation, 20 plus 0.27 is nothing, but 20 plus 1.8 would become 21.8, which could be multiplied to the every equation. I'm just going to go back here. See, we are going to talking about this value, 20.1 into 10. Okay, so if this value, if you minus the, if you add only 0.2, it doesn't matter. But if this is addition is 1.8, when you have a dissolved oxygen, this could become 20 plus 1.8 into 10. So everything gets magnified. The error could be as much as 20%. So please remember that whenever there is a dissolved oxygen, whenever there is FiO2 higher, if PO2 is say more than 100, always consider dissolved oxygen. It's very simple. It's what you're doing, but you need to add this value. Okay. So I hope all of you are clear. See, this pre-oxygen, it is okay. But in post-oxygen, this is how you calculate QT. VO2 is what we come from the book. Saturation of artery plus SaO2 with this, and plus, this varies because PO2 of vena cava is different from PO2 of artery. So this will vary. Remember that when you are doing saturation with dissolved oxygen, for each of them separately, you need to add that volume. That 1.8 may be at arterial side, but that 1.8 may not be that venous side. So remember, you need to do that. I know it looks a little complicated, but remember the whole formula. Whole formula is VO2. There's no doubt that doesn't change. Arterial oxygen consent, so that will be saturation into hemoglobin into 1.36 plus a dissolved oxygen, okay, minus SVC or mixed venous, again hemoglobin into saturation into 1.36 into 10 plus 0.03 into PO2 of SVC. So PO2 of SVC is not same as PO2 of iota. So you can't add it at the end. You need to add to each of them. See, for example, here the addition here was 1.5 ml. So oxygen carrying capacity of iota here was 20.1 into saturation of iota plus 0.03, which is into 500, which is PaO2, partial pressure. ABG machine will give. But see, the same thing for vein, saturation was 70, but the dissolved was 40. So dissolved contributed 1.5 here and dissolved contributed 0.12 here. And into 10 is common to both. Okay. So remember, the error will be magnified by 10 times if you are not careful. Okay. So dissolved oxygen has to be calculated separately for SVC, separately for aorta, separately for pulmonary artery, separately for pulmonary vein, if possible. Sometimes it's just not possible for pulmonary vein, you have to assume it. But this is how we do. So remember, when will you use dissolved oxygen? Whenever the patient is breathing 100% oxygen. All such cases, along with saturation based calculation, you need to add 0.03 into F5 into PaO2. How do you get PaO2? ABG machine. ABG machine has, and you know, ABG machine also gives total oxygen if you want. If you have the total oxygen capacity which is written, you could take it directly here. You know, that's one advantage of ABG machine. It might, that will give you this value straight away, both on the arterial and venous. If it is not there in your machine, you will have to do this mechanism. Okay. So what is Q effective? It's my favorite, and I'm sure all of you understand. One part of today's class is to understand Q effective. So I think today's class, apart from basic, which all of you are pretty much aware, I want you all to remember two things. One, when to use dissolved oxygen along with saturation, that is whenever you are giving high flow oxygen, and what is Q effective. Q effective is the amount of systemic venous return which reaches the lung for oxygenation. That is Q effective. In absence of shunt, they are all same. QP and QEP, Q effective, all of them are same and it's easy. But in presence of shunt, it varies. Remember something. The denominator for Q effective is pulmonary venous saturation, which is the highest saturation in the chart all the time, and mixed venous saturation, which is the lowest saturation, which could be SVC or SVC plus IVC divided by whatever formula. So you have a highest minus lowest. So the denominator is the biggest. Maybe it is 30, maybe it is 35, and hence this, because the denominator is biggest, among all the flows which you will have, the least flow will be Q effective. It could be equal to systemic flow, it could be equal to QP, it could be equal to QS. But if in a bidirectional flow, in cases like admixture physiology, like single ventricle, like some TGA, QEP will be the least value. Remember, if you are getting QEP more than QS or more than QP, your calculation is wrong. QEP has to be the least value which is available all the time. So in absence of shunt, it is all same. In presence of shunt, it is the least value. What is left to right shunt? QP minus QEP. Sorry, not QS. QS in presence of no, otherwise it is QP minus QEP, and right to right shunt is QS minus QEP in a bidirectional shunt. Remember this formula. If there is no, otherwise you just minus those two, that will be the amount. But if there is a bidirectional, QEP is the least value. The left to right is QP minus QEP, right to left is QS minus QVP. So let me just repeat QVP, amount of systemic venous return entering the lung for oxygenation. Formula denominator, VO2 is common anyway. Denominator will be pulmonary vein saturation or pulmonary vein oxygen minus mixed venous. Highest, least. Hence the value is always the least. Okay. Now, how do you diagnose shunt lesion? Shunt lesion, you need step up. So remember, there are books will give you multiple values and different books will give you different value. But what is important is to, if it is a mean value, remember 755. And if it is the highest value, it could be 11, 9 or 10 and 5. Remember, from artery to ventricle to great artery, the number is always 5. This number varies. I want you to remember 755 because that makes it easy. Remember 755, but also remember it is different. And what is step down? You don't consider step down. Step down is when systemic saturation is less. Okay, more than 2% difference is considered step down from LV to aorta or aorta to descending aorta. But use it only if the saturation is less than 92. Some books will obviously give you 95, but that could be error because normal people also has 94 saturation, but no normal person typically has saturation less than 92. So if the saturation is less than 92, then 2% step down is what is important. So step up, please remember 7.5. I mean, there are multiple. Mosadam gives 966, Grossman gives 755. Garson gives different value. So please remember the Grossman one, which is 755, or Mosadam one, which is 966. I want you all to remember 755 because it's widely accepted, but also understand there are different schools of thought about different. So I think you could remember 966 or 755. Again, the same thing, showing different books giving different values, but typically you see 755 is what is there in most of the time at any level from SVC to PA. 7 is always significant, anything more than 7, but from grade RA to RV or RV to PA, if it is a mean sample, even 5 is more significant. How do you quantify shunt? After you do the calculation, you will do a QP by QS. So quantification less than 1.5 is considered clinically, anything more than 2:1 is considered significant. But in echo and in cath, 1.5 is considered significant. Less than that is considered a small shunt. Less than 1 will be right to left shunt. More than 2 is it's a torrential shunt. Okay. Now, how do we do? What is the importance? Now, the other thing is calculation of resistance, pulmonary vascular resistance, especially in congenital heart disease. So you need to calculate PVR, you need to calculate SVR, you need to calculate PVRI, and you need to calculate the ratio. Resistance is opposite of flow. No, that's the common rule. More resistant, less flow, less resistant, and resistance is directly proportional to pressure. The formula for PVR is mean artery pressure, which is PA. Now it's not PV, PA, higher pressure, minus either pulmonary vein pressure, which we don't get. So it is LA pressure or PCPW divided by QP. And if you do that, you get the number which is in Wood's unit. 1 Wood unit, this is again a very important question, is 80 dynes divided by centimeter to the power 3. So this is Wood unit in name of Paul Wood, who is one of the greatest people who did lot of autopsies and who has told us our understanding. So resistance is nothing but pressure, which is the difference between artery and vein for any system, divided by the flow. That is pressure. So, you know, the PVR is high at birth and it comes down later. And there are, you know, values, we'll come to that. Now, there are also lots of defects. You know, PVR is very variable, especially hypercapnia and hypoxia increases PVR. And oxygen, you know, oxygen is one of the very potent pulmonary artery dilator. Prostacyclin, inhaled NO2, isoproterenol, amlodipine, high dose calcium channel nifedipine at that time. These are the things which are used to look for reversibility. Typically it's been oxygen now, but remember there are other things which are important. So what is SVR? Mean aortic pressure divided by mean RA pressure, artery minus the end chamber, divided by the flow. Typically around 20 is considered normal. Okay, SVR in children and adults is around 20 to 22 is considered, whereas pulmonary normal is 1. 1 is normal, but up to 3 you're okay. How do you calculate SVR? Aortic pressure minus RA pressure divided by QS, and PVR is pulmonary pressure minus LA pressure divided by QP. How do you get SVRI? Remember here, this is something which you should understand. To get QS QP, you divide. That's the flow. Or to get body to index a PVR or a SVR, you multiply. Again, there are two schools of thought. There is one school which shows that's division, one school which thinks it's multiplication. But you know, there's one article which I can share that in the lots of world literature, 46% used this and 54% used others. So remember, the confusion is not at just our level, the confusion is at all level. But since you're dividing a flow, it makes sense. You multiply a pressure in resistance. So here PVR into body surface area, because the unit is meter square, you know, it's wood meter square. It's not wood by meter square. So that makes sense that we multiply body surface. So both PVRI, SVRI multiply the body surface area and not divide. Whereas QP, when you want to index, or QS you want to index, you divide. Okay. Ratio is very important. That PVR divided by SVR ratio more than 0.25 indicates that it is definitely operable. You know, you could go by 1/3, 2/3, less than 1/3 definitely operable, more than 2/3 very unlikely to be operable. Between 1/3 to 2/3 the ratio is intermediate. That's where probably you should do oxygen based reversibility test, and that helps. Okay, remember 1/3. Less than 1/3 you don't need a vasoreactive test, especially if the shunt is more than this. If it is less than 6 it's okay, but again this is variable. ASD has 5, VSD has 10 and PDA has 15, because PDA, even with high PVR, if you occlude and show that there is a fall in PVR, you know, the pressure, especially PVR, you could operate. For ASD you should be careful, because ASD, the pulmonary vascular resistance change, is maybe independent of the flow, and they behave very badly if you close VSD. So cutoff traditionally for exam is 5, 10, 15. 5 for ASD, Woods unit, 10 for VSD and 15 for PDA. Okay. Reactive test, this is important. Ratio less than 1.3 is very favorable. If it is 0.3 to 0.5, intermediate. If it's very high, again you don't have to do. Try 100% oxygen or NO, both can be used. If the PVR decreases by around 20%, PVRI, or the ratio decreases, or it comes less than this, and if the final PVR, you know, it should come to the operable range. So 20% change in PVR in a favorable side with decrease in wood unit and decrease in final ratio, it is sign of treatment. You could use that could be used for the patient may be sent for surgery in such case, but do not do it if the baseline is extremely high. If it's not high, you could do it. The caveat here is, which people are going to ask in exam, is cardiac output should not change. If the cardiac output falls and because of that the pressure falls, it's not considered. So maintaining the cardiac output, maintaining the systemic BP, if these things happen, if the PVR then it is beneficial. Okay, you could use drugs like adenosine, nitric oxide, prostaglandin, or oxygen. Remember to you take all this name. Typically it's only oxygen which is tried in cath lab, although NO can be tried because most places it is here. What is a positive response? Fall in pulmonary artery, especially mean and diastolic. Systolic may not fall. As we will see in example, the systolic PA and RV is decided by the size of the shunt. If the VSD is big, RV will be equal to LV. If PDA is big, PA will be equal to iota. No, because the size is big. You remember, you open 2 rooms and you connect 2 rooms, the size itself will decide the pressure. But the flow is independent of that. Just because it is big doesn't mean it is irreversible. Okay. So what decides? The mean pressure is low and diastolic pressure is low. If the mean and diastolic is low or it falls, it is helpful. Fall in PVR with unchanged SVR, that means systemic flow should be maintained. Only then it is operable. There are times because patient becomes sick and the whole cardiac output BP from 90 comes to 60, and then you show a fall in pulmonary vascular resistance. It is not useful at all. Cardiac output should be maintained. QP should increase. The diastolic pressure in PA and the mean should fall. That is when you say that there is a positive response. Like, just look at this example. We have baseline hemoglobin, body surface area, very small 5-year-old child. If you see that RV, you look at this, the RV saturation is 80, PA is almost same. There is slight systemic desaturation, no? So, 95, it's around 93. So we are worried that although there is a significant step up here from 62 to 80 is 13, but there is slight step down here. So what do? We do the calculation. 1.36 hemoglobin, which was 13, into O2 saturation, depending on, into 10, and you do the formula. So QP was 2.57 and QSS 1.97. Okay, in this case, the same example, we did the calculation. So QP is 2.5. So QP by QS is more than 1.3. But the size of this, if I go back, RV pressure and LV pressure is almost the same, indicating the size. It's a big VSD. In a big VSD, this much shunt is not considered enough. So you are worried that pulmonary vasculature could have gone into obliteration or Eisenmengerization. So you calculate the PVR, it is 19.8, SVR is also high. The ratio now comes to be, PVRI is 10 points. See, multiplication. Remember, PVR, SVR is multiplication. And when we take the ratio, it's 0.45. When we take the ratio, it is 0.45. So this is how we calculate. I'm sure all of you know the formula. We're going to see much more example. Systemic is aortic pressure minus RA divided by QS. Pulmonary is PA minus PV divided by QP. Because of the small PV value, they have left it. Resistance is PA minus LA divided by QP. Okay. So you have this resistance, you have this resistance. If you do take ratio 0.45, what did we discuss? Anything less than 0.1/3, 0.3 is operable. Anything more than 0.7, not operable. So this is mid zone. So here there is a left to right shunt which is 1.3, but the resistance wise the pressure is equal, but that's okay. But shunt is not as much as the pressure you want. So what would you do at this point? You would actually start oxygen, no? So let's see that and what happens when they give oxygen. So this is, so when they give oxygen, I think it's when they give oxygen, you realize there is a significant step up, the PA saturation goes up to 80.5, aortic saturation also goes up. The QP is now 15.8 liter and QS is 4.1. The shunt is too high now, and this case will be easily operable. Okay, so that is what you do. So here again, if you see, this is a bidirectional shunt. So in any case of when do you want to do? See, you look at here, the LA is 88 and the femoral artery is 89. So these are the cases where there is, see, if you see the venous side 82, 83, 81, 70. From 70, there is a huge step up here. Okay. SVC, IVC, if you take mixed ones, there is definitely step up and it starts at SVC itself. So there is a left-right shunt here. Okay. And you look at systemic saturation, there is systemic desaturation, there is right to left shunt. So you have a evidence of bidirectional shunt. Remember, calculate the QEP, which is oxygen concentration, same as other formula, PV minus MV. What is MV here? MV will be SVC plus IVC. So when you do that, or it could be IVC here because you think SVC is not the MV. SVC, the blood is already come. So you're taking 90 minus 70. So Q effective was 5.4 liter. QP was 6.8 liter and QS is 10 points. So there is a higher QS indicating higher right to left shunt and lower left to right shunt. Okay. So don't worry about those examples because we have 20 more examples which we are going to do. But before that, I'm going to tell you approach and we are going to take maybe I think how many minutes break? It's 8:10. So we're going to meet in maybe 8:15. Okay. So, but before that, before we log off for 5 to 10 minutes, exactly sharp 8:15, we'll meet here. So have a cup of tea, walk around. But before that, I want to tell you something. How to analyze the data. That's what we are going to do then the next step. To analyze the data, what's extremely important is to first analyze whether the data is correct. It could be absurd. The chambers could be wrong. If it is wrong, discard it. Tell people it's not right. That's the first step. Second step, look at saturation. Saturation gives you anatomical, it gives you a physiological diagnosis. It tells you this is TGA physiology, this is left to right, this is systemic desaturation. Always look at saturation. Once you are sure about saturation, then look at pressure. And if the pressure actually tells you that anatomical diagnosis. So first make physiology. So what do? Data, right or wrong, or it is absurd. That's the first step. What is the second step? Saturation. Look at saturation, make up your mind. I am dealing with this, I am dealing with that. And then once you have made up that mind, then look at the pressure. Do not interchange. It produces a lot of problem. So with this, I think we will take yeah. So then, yeah, I'll quickly finish. Level step down can occur anywhere. We have some example. Can occur at atrial level, pulmonary vein, anywhere. Step ups. Atrial level causes, all of you have to know, ASD, PVPVC, Gerbert's defect, VSD-TR, RSOV, and coronary AV fistula. 6 or 7 causes at atria. Similarly, 6 or 7 causes at ventricle. Low ASD is important. If it's a low ASD, it could actually go to ventricle and not at atria. PDA, PR, RSOV, atriocanal, coronary AV fistula. All these causes should be known. Step up at atria, step up at ventricle, step up at great artery. So all this you have to know. I'm sure all of you know by heart. Plus we will be discussing it again. Okay. If there is a desaturation, it's important to look for if the desaturation at pulmonary vein, it's either lung disease or it is shunt. Less than 92 is desaturation for all purposes. Look for admixture. Admixture means there is also a step up. Along with step down, there is a step up. That is admixture physiology. Okay. So you have, we'll come to this. Now I'm going to pause for some time. It's 8:08 in my watch. 8:15 is where we'll come back. And yeah, we will discuss 20 examples. We'll take around 25 to 30 minutes to do that. So take a break now for 5 to 6 minutes. Okay, I'm going to pause the share. Can we start now? Rohit?
Yes, sir, we can.
Yeah. So everybody's fine. Any questions till now? The doctor is there?
Yes, sir. So we have received some questions in the question and answer panel. So maybe I think we can take all those questions once we are done.
Before we go to the first one, let's take some of the questions. Yes. Then we'll go to the cat data.
Okay. So the first question is, how can we calculate shunt from dye method?
Okay, dye method, it's depending on you need to calculate the dye concentration.
Yes,
you
sir.
know the amount, amount of dye which you have injected. So you also know the amount of dye which you are going to get. So imagine you inject say 5 gram, 10 gram, whatever, and later if you find that the amount of dye in that particular area, whichever you want, is say 0.05 by ml. So you know the flow across that system. It's okay. You understood, no? It's like imagine a beaker of water and you put 5 grams of dye. Okay. Now you sample the water out and you find the amount of dye is 5 milligram. You put 5 grams and now you find that particular ml, 1 ml as 5 milligram. That means you can calculate the amount of the fluid in the beaker. No? So 5 gram is spread across that. So that will be 5 milligram by 500. I think it will become 1 liter. So that's how you calculate. You know the amount of dye you have injected. You're going to see the concentration of dye in a particular chamber. Okay. So imagine you give it in PA. It will go everywhere. And then you check in the one of the radial artery and you see the per ml the concentration. If you see, you know the amount of flow across that organ. That's how you do it. Yeah.
Sure. Thank you for the clarification, sir. The next question is there any thumb rule to follow while choosing a catheter?
Okay, there are some rules and I'll be discussing a little more in the next class, or maybe the third class. So that's where we are going to discuss the catheters. Both that and angio, and that angio we are going to discuss. Just as a rule, typically right side catheter, you can use a balloon tip or a simple one. NIH is a typical catheter used on the right side. You could also use fan, which is balloon uploaded. There are different catheters for angio. There are different catheters. I think we will keep it for the third class, where we are supposed to describe the catheter as soon as we see it. And make sure there are 5 slides on catheters and how to choose them.
Sure. Thank you so much, sir. So, sir, you want to go ahead with another question? Or
Yeah. I want to case and understand what people have understood. That will be better. Then we'll go to data analysis. Yeah.
Okay, so the next question is, what should the sampling criteria for high-risk patients or elderly patients?
To look at that or
So the question is, what should the sampling criteria for high-risk patients or elderly patients?
No, I think elderly doesn't matter. The problem is children. See, if there is a newborn and when the blood volume is low, that we minimize the sampling. Otherwise, you don't matter in other individuals. So if it is a 1 month child, we would minimize. Important there is to whatever bed we aspirate, we need to put it a little bit back. So imagine I aspirate by 1 ml, then take 0.5 ml for sampling and keep the rest of the blood back. If it is an adult with say 5 liter blood volume, we don't do that. It discards the sample, we don't inject. So vulnerable group here is actually a smaller children with lower blood volume. So make sure only sample blood is taken and not remove much blood. That's the key. Otherwise it should not matter. You could minimally you need to have around 7 samples, maximum you can have around much more samples.
Yes. Sure. Thank you so much, sir. And another question which is, how do you give 100% oxygen without actually intubating the patient?
it's never typically 100%. So you need to put it on mask, not a leaky mask. Almost like a navy. When I make a mask, where both this is covered and you completely cover it and keep it. Not be 100%, but it will just a significant oxygen. This one. It may not be 100, but it will still be significant. Yes.
Okay, sir.
Any other question?
Yeah. As of now, I don't leave me good questions. Maybe we will the education.
Okay. Let me just push this one. Okay. Fine. So let's now go to the first one. Now what we will do, Dr. Dayasagar, I'm going to go to the first question, and I'm going to wait a minute, and I want you to give me some response from people, and then we'll analyze. Okay, sir. Okay, I'm going to put the first question, so please go through this question. I hope my video is not obstructing you. So this is a 66-year-old asymptomatic white test-tube 3/6 murmur, and this is what you find. So please go through this example. I'll also tell you how to interpret after we get the answer. You need to type your answer. So please type the answers, and I think Dr. will tell me what I'm not able to see your answer directly. No names will be called, so don't worry. Just put your answer, and I'll wait for a minute. Yes. Then we'll go to approach. So I have, I think, all these slides are prepared by Dr. Rocky, so we need to thank him right away, both the first part and the second part. Thank you, Rocky, for doing it. What we'll do is, I'm going to take a minute, you give the answer, I'm going to give an approach on how to do it. And remember, this is something which is very important, because this is how your OSCE is going to be. They're going to put it, they want you to give differentials, they want to give this. It's just an extended spotter, so don't worry about this. So you need to know CAT data, you need to do CAT tracing, you need to know angio. All three we are going to discuss in subsequent Friday. Apart from this, you need to know ECG, you need to know X-ray, and echo. So probably these will be chunk of your, OSCE. And some may be clinical case and clinical question and videos, because it's new for everybody. We really don't know how it is going to be. So do you see any responses, Dr. Gupta?
Yes, sir. So I think the most common response that we are getting, sir, is PAPVC.
Oh, that's good. How many of them gave that answer?
I think we have some 7 to 8 participants saying it is PAPVC.
Yeah. Any other answers? That's good, actually. I'm impressed.
We have a couple of other responses also, sir, like restrictive ASD with PS, PAPVC with sinus venous ASD.
Okay.
ASD-PS.
Okay, so lots of good answers. So I think, so let's see, I'm happy with this, and let me go through the analysis. Let's see whether it's right or wrong. Let's go to analysis. So there is definitely a step up from RA, SVC to RS. Typically mixed venous is 3 SVC plus 1 IVC divided by 4. But, SVC is enough for all practice. So there is 13, the saturation jump is as much as 13, which is high, which is quite high. And we look at then from RA to RV to PA, there is nothing. So as I always tell you, look at saturation first. Do not look at pressure. And in systemic pressure, they are almost same. Although the wedge is always 100, pulmonary vein is assumed most of the time if you don't take, and it is the systemic saturation if there is no desaturation. If there is desaturation at LA, you take it as 100, okay? Or 98, but 100 will be preferable. But otherwise, it is the systemic saturation. No systemic desaturation, significant step up from SVT to RA. So that much is color. Now, what are we thinking? There are 6-7 causes. It could be ASD, most common. It could be single atria. It could be TAPVC. It could be PAPVC. It could also be Gerbots, where it is VSD blood going into RA. It could be VSD TR. it could be RSOV to RA, and it could be coronary venous, coronary fistula to RA. So there are 7 or 8 causes, and now we need to understand which of these is the right answer. Okay, and they've given the clue. Now let me look at the pressure. Now RA pressure is 5, which is normal. But if it was ASD, RA and LA pressure should have been equal. No, we don't have LA pressure, but we have a PAW, that is a capillary wedge pressure, that's 10. So 10 and 5, so there is definitely no ASD. A large ASD, see, size equalizes the pressure. That's what we have been discussing, the size equalize. A large ASD, the pressure would have been equal. So it's not equal. It could be restrictive ASD as discussed, but typically restrictive ASD shouldn't have produced so much shunt, but it is possible, especially in elderly, like Lutenbacher kind of physiology, you know, or where there is LV dysfunction or some reason the shunt could be more than the size itself. So it is possible. So restrictive ASD possible, unlikely, especially in 6 years old. But because there is wide split, but you look at this, it was not wide fixed split, it was wide split. That's why I'm impressed. Almost all of you did pick it up, and I'm actually impressed with that. Now, the other point, there are people who discuss that. So that part is fine. LV is connected to aorta. This is what I was telling. Anatomy comes from the pressure. So first thing to see is PA is 30, RV is 50, possible. So RV is connected to PA and LV is connected to aorta. So the connections are okay. Left side pressure, everything looks fine, but the, you know, so it is likely PAPVC because of the clinical feature and not ASD. Restrictive ASD is definitely differential. Is there a PS? That is the next question. RV is 50, PA is 30. Is there a PS? Probably no, because ASD itself or any shunt like this can produce the pressure difference up to 40. If you read Moss and Adam, it could be even up to 70, but up to 40 is possible. If there was really a PS, the mean PA pressure would have been lower. The fact that the mean PA pressure is slightly higher indicates all this, and the difference is only 20. So we don't think there is PS, but this is all because of flow. Okay, so what are the possibility here with all the clinical feature? Very likely the diagnosis is actually is PAPVC, and atrial septum could be intact, but it could also be other things. Anything producing little more left to right shunt can produce the same feature, but this is the most likely diagnosis. Differential will be actually a smaller ASD with some restriction, some problem in mitral apparatus. But you know, if you the PCWP and LVED, there is no difference. You know, if this was extremely high, then you are worried about a restrictive ASD with say mitral problem. But here the connection seems to be fine. So you know, it's very nice that most of you did get it right, and I'm happy. So it's good. Okay. So remember, step up in RA. Remember all the causes. Always look at saturation first and then look at the pressure to make anatomical diagnosis. Okay, so can we go to the next one now? I'm going to put the next one. Okay, this is the question. Again, I'm going to give you a minute. Please make a diagnosis, and Dr. Gupta will help us with reading it out. Yes. So as you get answers, please start reading out so we'll understand the mood.
So there is a clarification which is required from one of the participants related to the last question.
Okay.
And it says that don't we expect a high V wave in RA if it's PAPVC, sir? Especially with an increased flow with wide split.
Yes, but it's not a must. You could even have a high A wave. So you are assuming that V is because of the flow, but that's more you know, the A and V are more related to compliance of the chamber. Okay, even if the flow is higher, it's not necessary that RA is less compliant. So V will go up if RA is less compliant. Okay, LA typically is less compliant. That's why V is higher. But when you're dealing with RA, if RV dilates, RV takes the blood, then RA need not be less compliant. So it's not a must to have a bigger V wave. Not a must. It is possible. If it is RSOV to RA, invariably V wave will be bigger because there is torrential flow with pressure, which is going to alter. RSOV to RA has V wave, not A wave. RSOV to RV has A wave. But if it's just a PA-PVC or a TA-PVC, V need not be high at all because if the distal chamber, which is RV in this case, could take this, and the shunt may not be 2 or 3 or 4:5. It could be slightly higher. So it's not a must. Any answers for this question?
Sure, sir. So we have a couple of answers for this question also, and
Yes.
the responses are it is normal.
Yeah. How many wrote it is normal?
So we have 4 to 5 participants.
And
saying it's
anybody
normal.
wrote abnormal? Any abnormality?
Not yet, sir. Not yet.
Very good. So again, it's correct. I'm going to put the answer. It is normal. So, it's important to pick up normal. The toughest in medicine is to actually tell anything is normal. X-ray is put up to tell normal is tough. ECG put up to tell normal is tough. Abnormal is easy. So, but I'm happy many in the group do understand. So if you look at the saturation, it's almost completely normal. IVC is higher than RA, but rest is fine. Venous side is fine. Pressures are fine. So it's actually normal or a very insignificant thing going on. But as far as cath is concerned, it is normal in every way. Okay. So remember, it could be normal also. So very good. Let me put the third one. And any queries I can answer till then, and people can answer the next question. Okay. Yes, the next question, and any other queries you could put. This I think people will answer quickly. Anybody?
Yes, sir. So we have a couple of responses saying RVSD.
What?
RVSD.
VSD, probably restrictive VSD, no? Yeah,
Yes,
yeah.
restrictive VSD.
That's good choice. So if you look at here, there is a always saturation first again, no systemic desaturation. So that part is clear. Step up at RV and step up of 10, which is very significant. No further step up between RV to PA. That's fine. And what do we see here? Pressure seem okay. Now, if the VSD was if the VSD was actually big, if you see LV pressure and aortic pressure are again matching, RV is below PA, anatomically it is fine. But what you see is the RV pressure is low, okay? RV pressure is low, whereas LV and aortic pressure is high. The pressure, now the size decides the pressure. If it was a small one, the pressure will be low. If it is moderate one, the pressure would be little higher, but not systemic. If it's a large VSD, then it would be systemic pressure. Since the pressure is low here, so it is most likely a restrictive VSD. But please remember something, that it's better to show at a step up of when you answer this, better to tell it as step up at RV in your exam, not here. Here I'm okay with that. Step up at RV, and the causes is most likely either restrictive VSD or all other causes. What are the other causes? A low ASD could produce the same thing, no? A low ASD. It could have been a small RSOV to RV again. It could be coronary venous fistula to, RV, and VSD is already thought. A PDA PR also can produce this feature, but not to this extent. So most likely, you should probably, give this answer, but allow your examiner to ask you more questions. Step up at each of the chamber, you should be able to answer in a single breath. Among them, try to make a different diagnosis. I'm sure most people are making it. So what is the QPQS? That is the next question. So based on this calculation, the BA body surface area is one, same example, body surface area is 1 point, oxygen is 182 and hemoglobin is 13. So the QB from calculation was 6.08, QS is 4.24, QP by KS is 1.4:1, PBR, which is actually QP divided by the changes in pressure which are already given. PVRI is multiplication. Remember, don't divide PVR, it's multiplied by 1.4 and SVR and SVRI and take a ratio. So you have a QP by QS which is not too high. So it's small in size and as well as small in shunt. Remember, all combinations are possible. In the VSD based on size, we divide into small, intermediate and large. Okay, large will have equal pressure, intermediate is 1/3 to 2/3 of iota, it will have say 40-50 RV pressure but not as much as systemic, and small will be small like this. But each of them can have shunt more than 2:1 or less than 2:1 depending on the pulmonary vasculature. Size itself is determinant of the shunt in a small percentage. In majority, size doesn't decide. If it is reasonable, then it is the flow. So in this case, it is 1.4. So if I have to ask, what will you do with this VSD? What is the answer? Can people type? This VSD in a, say, 18-year-old, what would you do to this VSD? Anybody typing?
Not yet, sir.
Okay. So how do you manage this VSD? I'm agreeing it is a small VSD and this is the shunt.
And, there is a comment also, sir, that why LVEDP is high.
LVEDP is slightly high, it's 15. So that should be okay. That could be because of the slight increase in flow, but it's not too high. And there's also systemic hypertension, which could be raising the LVEDP slightly. The mean aortic pressure is actually 100, which is little higher. That could be rising the LVEDP. May not be that significant. Up to 13 is normal, it's slightly high. What would you do for this case?
So there are some responses like do nothing and follow up, close as it can cause IE.
Yeah. So this
follow
is
up, look for AR.
Understood. Yes. So the answer would be do nothing and follow up, because for sake of IE, you do not close a VSD, because the traditional surgical description still holds true. VSD is an intracardiac surgery, so risk of mortality is 2%, whereas PD is extracardiac, so risk of mortality is less than 1%. So for a risk of IE is typically 0.6 to 1% in lifetime. So you do not close a VSD for risk of IE. You don't do that. You will, but if the shunt is more than 1.5 or typically if it is more than 2, you should close it. It can be closed surgically, can be closed medically. So remember, when they ask you or ask you, this may be the question. You may have to do these calculations quickly and write the plan, because if it is 5 marks, they're going to give 5 to 8 marks. So make sure if there is a calculation needed, which you could be doing it right away. Okay. So small VSDs we don't close. Okay. The fourth question. I'm happy most of you are answering fast and it's going faster. So let's see this question. Please start reading out whenever. And most of you must be knowing to calculate the at least QP by QS. That can be simply done by this, that's by the numerator now will be iota minus SVC and denominator will be pulmonary vein, which will be 99 in this case, minus RA. Okay. SVC or RA will be the numerator. Denominator will be PA minus PV, okay, or PV minus PA. So you will get a fair idea whether the shunt is more than 2:1 or less than 2:1 quickly. So you'll be able to answer that question. Any answers, Dr. Gupta?
So yes, so we have some responses saying moderate VSD.
And the shunt is likely to be? Yeah, I mean,
Yes.
So, yeah, it's right. VSD left to right. Why do we think that? Because there is step up at RV. So remember in exam, you need to start with telling step up at RV of 14, which is very significant. No systemic step down. And then if you look at RV pressure, RV is connected to PA, no doubt, and the pressure is more than normal, but it is not as much as iota. So it's a moderate sized VSD, and shunt can be calculated, I hope. Yes. So
yes, so we have a couple of other responses also. Okay. Moderate restrictive VSD with mild PAH.
Correct. That's good, and the PAH is likely to be because of this one. Now imagine this case. I think the shunt here also is, what would be the shunt here? It will be 84 minus, 65, which will be the numerator, divided by 98 minus 84. So if it is more than, what would you do to this patient? Imagine the shunt is more than 2:1. I have two questions. Okay. How will you manage this patient? What is the chance that this patient Eisenmengerizes? So two questions. Let me see what are the answers we get. I'm really sorry about this, that I am not able to see any of your response. But Dr. Gupta will be kind enough to, read it up for us. Okay. Two questions. If the shunt was more than 2:1, I want you to calculate. It looks more than 2:1. If it is more than 2:1, what will you do to this patient? And what is the chance of Eisenmengerization? We are assuming it is VSD. Okay. That part is fine. Do we see some answers?
Not yet, sir.
Yeah, there's also a lag of 15 seconds, no? So we'll have to give that to them. Yeah.
Right. Yes, so we have received some responses, and
Yes.
they say closure of VSD.
Yes. So if it is more than 2:1, you close. Why do you close? Because there is long-term problem of LV dysfunction. So whenever shunt is more than 2:1, or in echo, you see a LA-LV dilatation, you think that there is a chance of this patient, going into long-term LV dysfunction. So you do close this VSD, typical either device or surgery, depending on the site of VSD. That, as I told you, it's like cat. Once you know it is cat written in this format, this alphabets, you know how to manage it. Now, my question is, what is the chance of Eisenmengerization in this VSD? Imagine this is a 3-year-old or 4-year-old child, and you find this. What is the chance of Eisenmengerization? Any answers?
So we have response for that as well, and
Yes.
it says 50%.
Yeah. No, the chance, see, for Eisenmengerization, you need two things. Okay. One, shunt. Shunt is here, 2:1. The other thing what you need is pressure. Eisenmengerization occurs in large VSD. When you manage large VSD, you are worried about Eisenmengerization, because then the pressure between LV and RV is same. So is PA and iota. High pressure with high flow denudes the endothelium of PA and thereby produces irreversible PA changes. A low pressure with high flow like this, chance of Eisenmengerization is only 3%. Okay, it's small, it's just 3%. So chance of, because the RV, so any restrictive VSD restricted by the size, where there is gradient between LA and LV, the child could be in failure, but chance of Eisenmengerization is very less, 3%. So Eisenmengerization occurs when there is a large laminar flow in echo and a torrential flow. It has to be flow and pressure. I hope you all understood. It's not just shunt more than 2:1 which produces Eisenmengerization. It is also pressure. So if it is big VSD, equal pressure, then shunt, Eisenmengerization is high. This will most likely go into failure rather than Eisenmengerization. That's only 3%. Okay.
Yeah.
Let me go to the next one. Yeah.
In fact, sir, we had quite a lot of responses saying less chance but possible. So I think it goes
correct.
with what you are saying.
Yeah, I think most of them did get it right, and that's good. This is an extremely good group we have got, Dr. Gupta. So let's see the next one. Yeah. Fifth question. So there is pre-oxygen and there are two datas. Please go through that and give the complete answer. You could type the answer. So you're able to see the whole slide, no? My photo is not obstructing it, no? Dr. Gupta?
Yes, we can see your video as well as the slides, sir.
The slides means complete slide. No data is, yeah. So what would be this case? And yes, that's question number 5. What would be this case? There's pre-oxygen and for some reason they wanted to do post because there is definitely reason to do that. So what's the diagnosis and what is the inference of the complete data? The responses, Dr. Gupta?
Not yet, sir.
Okay. I think it's because of the lag. I'm sure the people attending are so good that they will answer it within a minute. No? Yeah.
Right. Yes, sir. So we have responses. Large non-restrictive VSD, operable shunt.
Okay, that's the right. So you look at the pre. Let me only look at the pre data and pre pressure. So if you look at, there is step up, no, from 72 to 82, step up of 10, but there is also step down. Okay, so LV2. So there is a going by this, I find step up. What do I find in pressure? RV pressure is RV and PA both are high, so is as much as systemic. So systemic pressure with this makes me think that there is a large VSD which is bidirectionally shunting, but probably predominantly left to right. That's what I feel. So this becomes a borderline case. The person or child, whoever it is, may not be cyanotic. But what is reassuring even in this data for me is the diastolic PA pressure. So in absence of a major PR, diastolic PA pressure is important. Diastolic, there is a suppression. This is something which we'll analyze in the next class also, where we're going to look at the tracings and look at the tracing. And when you see the PA and iota simultaneously tracing, how are you going to tell whether it is Eisenmengerized or no? So here you see diastolic is 66, here it is 88. So there is a diastolic suppression, which makes us think that this probably could be operable even at this state, but it's borderline. So 100% oxygen is given in the method we described. The shunt increases tremendously here, 20, and the desaturation disappears completely. What do you see in pressure? Aortic pressures and LV pressure is maintained. PA, there is fall in systolic, which we don't expect much because the VSD itself will decide the systole, but the diastolic is fallen further, which is reassuring. If you go and do the calculation here, yes, pH with systemic RV, bidirectional shunt. So body surface area is 1.4 calculation. The pre-oxygen QP was 10, QS was 7, 1.3. See, PVR is 6.6, slightly higher. SVR is 9, PVRI is multiplication 9.2, 12 and 16. So the ratio is, if you look at this, it is 6.6 by 12. So it's around 50%. But post oxygen, the shunt is increased tremendously. But remember here, post oxygen, you need to take the complete data. You need to have the data also of dissolved oxygen, which is not given to you. But remember, all post, you need to use that. So 23 QS now is same or little less, but QP by QS now becomes 4.5:1. PVR decreases, the ratio comes down tremendously, from PVR divided by this. So this is an operable case, but don't wait too much. So again, reiterating, a large VSD with shunt or shunt little this side can Eisenmengerize. Eisenmengerization starts early, but not within first year. So if a child is born in VSD, large VSD, after 1 month the failure starts. At that time we do not directly send them. We manage the failure. You giving diuretic and giving digoxin. You wait for 1 year because that's the time it could become restrictive. If it becomes restrictive, that means the flow from laminar in echo becomes turbulent. You can wait. Then you operate between 3 to 5 years. Even though the shunt is higher. But if there is a laminar flow, even at 1 year, like 11 months, you find LALB dilated, but flow is laminar, VSD is not showing sign of closure. That is the time you subject the child to surgery at around 1 year, because Eisenmengerization below 1 year is uncommon. In a restrictive or moderately restrictive VSD, as such Eisenmenger is uncommon. So large VSD operate around 1 year to prevent Eisenmengerization. A moderate VSD, if it persists to be moderate, you operate between 3 to 5. A small restrictive VSD with small shunt, you don't operate unless they have history of I. Okay, so that's where we are. So this was a good data and most of you did get it right. So question number 6. Open to voting. So remember, the good part is we did a restrictive VSD, a moderate VSD, a large VSD. And while doing this saturation data, I think we did discuss a lot about natural history of VSD, which will help you in managing your own case, not just your exam. When you become practitioner and you look at VSD, your mind should be thinking in this direction. Yeah. Any answers, Dr. Gupta?
Not yet, sir. I think because of the lag, it takes around 1 minute of time to reflect the responses.
We are okay with that, yes.
Yeah. Yes, sir. So we have some responses saying TAPVC.
TAPVC? Okay. TAPVC?
Yes, TAPVC.
Okay. Okay. Any other response?
Restrictive VSD with PS. Moderate VSD with severe PS.
That's the right
PS.
answer. Okay. It's not
Yes.
TAPVC because step up from SVC is 65, 70. 5 is not enough. Minimum is 7. Even if you take SVC, you don't expect 5 is not enough. But from 70 to 95, 94 is a 24. The step up is actually at RV level. So you have step up at RVA level. Your mind is thinking about that. There is systemic normal saturation. There's a huge shunt though. That's what is making people think about it. But huge shunt can occur. And you look at the RV pressure and LV pressure. Yes, RV pressure is raised, but it's not as much as LV. VSD decides. So it's a moderate sized VSD. But what is also surprising is although RV is raised, PA is normal with a low PA mean. See, as I told you, if there is no PS, if it is the flow which is producing this gradient, very unlikely, more than 40 gradients are not produced because of flow. But if it is flow, then invariably the mean rises. Here if you see the mean has not risen, the PA mean is low or lower than normal. But there is definitely a shunt. So there is a RVOTO, but is it TOF? No, it's not TOF, because TOF should have equal pressure in RV and LV. That has to be a non-restrictive VSD. So this is VSD with moderate. It's a moderate VSD or moderately restrictive VSD with RVOTO. So I hope everybody followed. How did we pick RVOTO? There is a gradient between RV and PA. If it is only because of flow, which can happen in ASD most often, the mean pressure is higher. Here the mean is actually lower and the gradient is present. So there is definitely a RVOTO. So VSD left to right, not a large one, but a moderate one. But the gradient is produced by the PS. Okay. But shunt is torrential. There is a big shunt. If you do the calculation, the shunt calculation, that can happen even with, but this is not a TOF. Okay. So can we go to the next one? Any questions there? So seventh one, again, people can see and write it. Please look at all the numbers and then give an answer. Any answers, Dr. Gupta?
Not yet, sir.
Okay. I think it's a lag, so we'll have to wait for a minute.
Right. There are a couple of responses, but I'm not sure whether it is for this particular question or for the previous
Doesn't
question.
matter.
But it says Hoffman variant of TOF. Can we call it Hoffman variant?
Which one? This one or that one? For the previous one, no, you can't call, because in Hoffman variant, the RV pressure is higher than LV. You know, there is a VSD which is restrictive and the RVOTO is significant. So the last case, Hoffman RV will be higher than LV. In this case, RV was lower than LV. Almost all Hoffman RV will be higher. Okay. So because of the restrictive VSD, RV becomes supranormal in Hoffman invariably. Because imagine VSD gets occluded with a tricuspid leaf foot or something. You don't expect RV to be less than LV. In that case, RV becomes higher because RVOT was significant. Okay.
Right, sir.
That's just
and for this. Yeah. Okay, sir. And for this particular question, most of the responses are RSOV to RV.
Not bad. Yes. Any other differential? Anybody has written anything else?
VSD with AR,
yes,
small VSD.
Correct. Very good. I think that is good. So, you know, there is 70 to 7, which is 7 step up in RV and it's significant. Rest is fine on the saturation side. When you look at the pressure, you realize that the RV pressure is actually not high, very small, but the aortic diastole is low. Now, this could occur in two reasons. One is AR. Okay, VSD is definitely there. So it could be VSD AR. It could also be RSOV to RV, as somebody's mentioned. But the only problem with RSOV to RV is actually that if it was such a small RSOV that it's just 7 millimeter high. If you see shunt here is so less. If it was such a small RSOV, the aortic pressure should not have come this low. Aortic pressure would have been actually normal. So most likely diagnosis is a restrictive VSD with AR with the differential of RSOV to RV. Typically, RSOV tends to be larger, typically. And only larger one will have low diastolic pressure. So here, you know, the shunt is small. That means the RSOV is not shunting so much. Then ideally, its diastolic pressure should have been higher, aortic diastolic. So it's most likely VSD with left to right with AR being more significant. If RSOV was actually significant, shunting would have been high, and invariably a bigger RSOV has PAH. You know, the reason for failure in RSOV is not the flow to RV, it is LV failure. Remember that when RSOV presents, it is the LV failure leading to PAH which is present. It's not the flow itself which is producing failure, because RV can take it easily. Okay, typically a larger, very small possible, or coronary AV fistula also is possible, but a sizable, you know, any shunt to produce a lower diastolic aortic blood pressure should be significant enough to produce a significant shunt. We don't see it. So VSD with AR is the first possibility. Okay. The next one now. Yes. Yes, but with the differential, obviously. So the next question. Remember, all of them do have differential. There may not be only one correct answer, but differentials are part of the game. Yeah. Any answers, Dr. Gupta? Not yet, I think. No?
Not yet, sir. Not yet.
Already 9 o'clock. I hope we will at least finish some more questions. No? Yeah.
Right, sir. And in fact, we also had a request in the Q&A panel that if possible, can we take some of the questions during your next session also, if possible?
Okay, if possible. Yes, yes, definitely. Because the next session, we're going to do the pressures and we could take, I could get 3 or 4 of them and just show it. And yeah, next session, probably, this had too much theory, which was needed. Because you will be asked in exam. The next one will have more tracings and more this one, and I think the theory will be much lesser, and the third one the theory will be still lesser, and we'll have more videos playing and more it will definitely be more interactive. Yes,
So
but
we
this
have
was
a couple
needed.
of responses on this question, sir. So
Yes.
it is some are saying ASD, RSOVRA,
Yes.
LSVCRA, ASD with severe PH. I think we have mixed response for this
Mixed
particular
response.
question.
Yes, I think it's good that there is a mixed response. That means people are understanding. But what do we see here? High RA is normal. Mid RA is high. There is a significant step up at RA, but beyond that, the step up is not much. So that's what we find. So step up actually takes it more at low RA, less at mid RA, and hardly any at high RA. Okay. And what do we see at the pressure? Systemic side is okay. RA pressure is raised here. That is something which is striking because it's more than LA pressure. And there is some sort of pH. Now, this could occur in a variety of conditions, which includes RSOV. But then in RSOV, if it is a significant one, you do expect a lower aortic diastolic pressure, which is not there. But this could also occur in VSD-TR, or more importantly in a Gerbaud defect, where the shunt is between LV to RA. It's very typical. What example is very typical of Gerbauds, but with all the differential. Could be ASD, but then you don't expect RA pressure to be so high. A small RSOV is possible, will mimic exactly this, and RA pressure will go up. It could also be possible with coronary AV fistula. LSVC, no. LSVC to RA doesn't. It's LSVC anyway comes to coronary sinus. LSVC to LA has different manifestation. But, yes, there are many possibilities. But this is very typical of Gerbauds, the example given. But other differentials should be considered and cannot be ruled out at all. So any of them is fine. So always in exam, when you are confused, start with the most obvious. If I had to give an exam, I would tell this is a case of step up at mid RA and lower RA. So along with the pH, which most of you mentioned. So it could be ASD, but less likely because of such high pressure. But it could actually be Gerbauds, rarely coronary AV fistula to RA, but torrential shunt or RSOV to RA. All of them is possible. RSOV is definitely possible.
And in fact, we had quite a lot of responses saying Gerbaud defect also.
Oh yeah, that's good. That's good. Yes, but differential is the key. Although it's very typical of Gerbaud, remember differential is the key. If it is your exam, make sure you put differentials. Okay.
Right.
So
and I think, sir, we can take
the question number 9.
Yeah, we can take a couple of more questions.
Yes, we can take. Okay.
Yeah, I think, sir, we can take.
Yeah,
if you
I think yeah. Thanks to Rocky, I think we have around 22. So people can say when to stop, but we need to cover some of them more, just to understand different physiology. If you see the way we have arranged it is to start with something like ASD, normal, it's arranged beautifully so that you understand the different physiology, different VSDs and how they matter, how they present. Now we have come to, we are going stepwise. It's not a random, don't think that these questions are very random. They're not. They're making us go through a process where you even understand the disease along with this. Okay?
Right, sir. Right. I think we can take a couple of more, and the good part is we have quite a receptive audience also.
Yeah. Yes. So what's the answer here? But I think, I'm sure all of our audience are understanding that if you're very systematic, these data are never a problem. But remember, look at saturation, make a diagnosis, then only look at pressure. And then with that, you understand what we are going to do. Yes.
We have quite a number of responses saying
Yes.
PDA.
Okay, so there's definitely step up at PA. That part is very correct. 84, no? From 72 to 84. No systemic desaturation. Looking at the pressure, RA looks normal. PA is elevated. So is RV, thanks to the PA probably. There's no PS. And aortic pressure. So if it is PDA, what kind of PDA is it? Like VSD, we need to talk about PDA. It could be a moderate size PDA with a large shunt. Mentally, you should be able to start, but definitely not a large PDA. If it is a large PDA, the PA and aortic pressure would be same, and thereby, because PA is higher, LV also, RV will be equal to LV. So this is not a large PADA. This is a moderate PDA. Shunt probably is torrential, means more than 2:1. So if you minus say 84 minus, so you'll have to do 98 minus 70, which is 28, divided by 99 minus by 29 by 50. So it's almost 2:1 shunt, and definitely operable. It's a moderate size. Again, moderate size PDA produces failure. They're like VSD. Eisenmengerization with this number is unlikely. That's not Eisenmengerization. IE is very likely, and this. So that's where we are. Can I put the next one now? So also RSOV to PA, subpulmonary VSD. Yeah, remember subpulmonary VSD also can have step up at PA, because here they didn't give LPA, RPA, MPA. It's PA. Outlet VSD presents with step up at PA. That's one more cause, but yes, PDA is very, very likely. So what's the answer for this? A full answer, So we are going in a, this just for us to understand all the first 9 questions were actually acyanotic. Now we are going to little bit cyanotic so that we understand the physiology here. So good. My voice is okay, no, Dr. Gupta? You're able to follow and understand, no?
Right, sir. It's very clear, sir.
Okay.
So there is a clarification pertaining to the previous question. Why not outlet VSD?
Yeah, that is one of the causes. There were 3 of them, no? It could be PDA, it could be RSOV to PA, or it could be outlet VSD. Yes, outlet VSD, or, it was written in the answer. It is a possibility. Moment you have step up only at PA, you should consider outlet PSD. So all the causes should be considered. But even if it is outlet PDA, it was a sizable outlet PDA which produced both RV and PA increase. So it was at least a moderate size. It's definitely possible it is outlet. Okay. That's why sampling should be done at all 3 areas.
Right, sir. And as far as this question is concerned, most of the responses are TAPVC.
Yeah. Anything more they have written other than in TAPVC?
Supra cardiac TAPVC.
Any signs about obstruction?
Unobstructive supracardiac TAPVC.
So I think people have got it right. So, minus SV are all sample relatively equal. This is very classical of admixture lesion at atrial level, admixture at atrial level. So this is a supra, SVC itself is high, so it's a supracardiac TAPVC. What do we do then? Look at RA mean and LA mean, because in this case, LA is at mercy of RA. So we look at RA mean, we look at LA mean. LA is at mercy, but the mean is same. And there is no much PAH. So this is the unobstructed supracardiac TOPC. All of you got it right. What is important is, if at all, if LA, RA with the same numbers here on this side, if this was say 10 and this was 5, then the obstruction is actually at atrial level, and invariably even that produces PAH. So to produce PAH in any obstructed TAPVC can have PAH. Obstruction could be at the venous end, any of the pulmonary veins. When they enter anywhere, typically infracardiac is always obstructive, but one more level of obstruction is intra-atrial septum itself. If there is a gradient between RA and LA, if the intra-atrial communication is obstructive, that's also obstructive TAPVC, and that can produce PAH. Okay, so I hope all of you understand that the obstruction need not be just at pulmonary vein, it also could be anywhere here. Okay, so with that, we'll go to the next one. I think we need to, diagnosis, supracardiac, unobstructed, all of you got it right. The 11th question, yes. So, can anybody answer this? If the answers are quick, we can, it's a technical glitch that they're not able to answer quick, I think. But as soon as they get answered, Dr. Gupta, just read it out so that we can go to the next question. Okay?
Sure, sir. Sure.
Any answers?
Not yet, sir.
Suddenly you'll get, I think, 10 answers, no? Yeah.
Yes, sir. We have a couple of responses. PAVM.
Sorry. PA?
PAVM.
Okay.
AV fistula.
Correct. I think they're all trying to tell it's a pulmonary AVM.
Pulmonary AV fistula, right?
Yes. Because see, what you see here is a systemic desaturation, and the desaturation, the venous side is okay here. Systemic desaturation starts with pulmonary vein. They are given a pulmonary vein here. Hence, it is a systemic desaturation. Typically, you have to take 2 pulmonary veins to be very sure. And otherwise, one particular pulmonary vein should show the fistula. So it's likely fistula and nothing remarkable in. So it's the pulmonary AVM. What would be a differential? Lung disease. Bad ILD also can produce the same. But typically, anytime whenever you have ILD, you have a PAH, so you don't have it. But yes, desaturation in pulmonary vein can occur even in lung disease, but this is very likely to pulmonary AVM. So I'm just going to tell you one more question which people, on this regard. One question same in TAPVC. So answer is pulmonary AVM. The other question which is asked, which is the acyanotic heart disease with left to right shunt, where the flow across all 4 valves is same. So I'm going to ask that question. Let me see who types it. Acyanotic heart disease with flow across all 4 valves is same. It's left to right. Prove one, Dr. Gupta.
Not yet, sir. There is a comment why there is stop down at aorta and FA level.
Further drop down, it's just a mixture, nothing else. I think FA, these are just the data. There's no further reason to do that. Must be just this one. So anybody wrote the answer to that question which I asked?
Not yet, sir. I think RSOV to RA. I'm
Yes,
not sure
that's the answer. Yes,
Okay.
RSOV to RA produces a left to right shunt at RA, and but then the blood goes through all the four valves. That is correct. So cyanotic with same flow is pulmonary AV fistula. Acyanotic with same flow is RSOV to RA. Okay.
Sure.
Let's go to the next question. Sorry. Yes. Okay. The next question. Okay. Question number 12. You see this and the previous question looks almost similar. Any answers?
Not yet, sir. Systemic AV fistula.
Yeah, systemic, that's correct. No, more than systemic. Yeah, but see here, the problem is LA desaturation, no? The pulmonary vein is fine, but the desaturation starts at LA. Rest, everything looks fine. So this will occur in systemic venous to LA drainage. Typically, this will occur if LSVC drain to LA. Okay, too much desaturation in this case. It occurs if it occurs into LA, or if there is, it goes to CS and the CS is unroofed. Well, there's too much of, this occurs with the systemic venous blood. It's typically LSVC. Very rarely RSVC, it can happen, but it's typically LSVC directly to LA or unroofing of coronary sinus with LSVC, because desaturation occurs at LA. A single atrium also produces some sort of step up in the venous side, which you don't see. It's only step down without alteration in any of the pressure. This is very, and the pulmonary vein is normal. If the pulmonary vein was abnormal, it could have been pulmonary AV fistula. Here it is a systemic venous to LA drainage. So if you have not seen cases like this, please remember this is one possibility where there is step down at LA. Okay. Any other comment or anything? Nothing, no, Dr. Gupta?
Nothing, sir.
Okay. I'm going to put the next question then. 13th question. Okay. Look at the saturation first, make the diagnosis, and then look at the pressure and fix this one. What we have done is we have, similar looking ones, we have put them together so that your understanding of all this physiology becomes easier. No? So we are going stepwise. So you're able to understand the overall physiology also, not just some random examples. Any replies?
Not yet, sir.
We'll wait, no problem. Let me
Right.
just see. Yeah, it's 9:19, so I think don't worry, by 9:30 we should be, 9:30 we should be done. I know it's been little long and this is taking some time, but it's very important you will take time and answer this. If I start explaining the whole thing before your answers, you will never think about these conditions.
Yes, sir. So we have a mixed response for this question also.
Yes. Next is
Hoffman.
good.
Yeah, so Hoffman variant of TOF with ASD, then ASD with PS, severe PS with PFO or ASD right to left,
I think most
Severe
of them got the
PS.
concept right. I'm happy. So let's look at the saturation. There is desaturation at LA. See, last case also had desaturation in LA. The case before also had desaturation at LA. That was the primary site of desaturation. The first case was actually pulmonary AVM because the pulmonary veins had desaturation. The second case had desaturation at LA, but all other, the pressure tracing were all fine. So it was a systemic venous return going into LA. Now there is desaturation at LA at the same level. This data of saturation looks the same in 3 examples, but you look at the pressure. Here you see a suprasystemic RV, very high RV, suprasystemic RV, and RA. Look at this RA pressure, which is way higher. There is RV which is higher, there is RA which is higher, and there is VSD. So almost doubled pressure in RV, and PA is typically very low. So there is a RVOTO, which is definitely there. There is a PS. RV is supranormal and dysfunctional because the diastolic pressure is higher here, RA is higher. So typically that means there is an interatrial and desaturation is at LA. So this is, I mean, again there are differential, but the one important thing is there is a severe PS which is producing a RV which is systolically fine but diastolically abnormal. RA pressure is high and it is producing right to left shunted RA. So you can call it triology of TOF if you want, but most likely it is a PS with intact septum producing shunted RA. Is it a ASD? Very less likely, because ASD, RA and LA pressure is equal. It's more likely a PF4 with the stretched septum which is producing. So the difference between PS ASD and PS PF4, even clinically, imagine there is PS with intact septum. If it is ASD, they get mild cyanosis in exertion, because in ASD shunt is decided by relative compliance of LV versus RV. So if there is PS, LV compliance is bad, so the right to left shunt can occur at rest or more so at exercise without RV failure. In ASD it is possible, but if it is PF4, it occurs only with RV failure because you need stretching. In this case, with 16 RA pressure, it is definitely stretched. So it's very likely a PF4 and LA pressure is not equalized. So RA pressure is way normal and pressuring on the other side. It's not surprising to have that. I have had one case where actually the patient saturation was 48 and the only problem was severe PS with the atrial shunt. The moment we did BPV, the saturation actually came, I mean, everybody died. It was a 60-year-old woman. Everybody thought it is a tough, no? All years, but the only problem was a PS. You open the PS, the saturation became 92 on table. We allowed some time for PA to subside and then manage the atrial defect, which was ASD in that case. So here it's likely PS PF4. Remember, PS PF4 shunts when RV fails. PS ASD can shunt even without RV fail. Both are typically called triology of TOF, if you want to call it. Is it Hoffman variant? Possible, I'm not telling impossible, but doubling of RV pressure compared to LV is unlikely because there is a VSD. Although it is restrictive, there is a VSD, restriction comes. So typically pressure is not this high. This high pressure you actually get is the intact ventricular septum. Okay. So severe PS with atrial right to left is the diagnosis for this. Okay. So 14th, so I hope everybody understood it. Now let's go to this question, 14th question. So last 3 case was desaturation at atrial level, were different physiology. One AV fistula, one LSVC or systemic vein, and one PS producing at atrial level. Now let's come to the next one. Any answers?
Not yet, sir.
Okay. Are people tired? Should we stop or do two more? We are going very systematically.
I think we can take one last after this. Maybe we can go till 15th question, and then maybe remaining one we can take in the next session, if it is okay with you, sir.
Okay. Yeah, I think that's a good idea.
So we have responses for this question, sir. It is Hoffman variant TOF, Hoffman, then TOF with Hoffman variant. I think we have a common response from all the participants as far as this question is concerned.
Yes. So, but more important here is, see, what you see here is there is a step up at RV. No, Hoffman typically doesn't have a step up actually RV. It's only step down. So what you see is step up at RV and PA, and there is step down at LV and iota, LV level. So step up and step down is indicating of a bidirectional shunt, and that occurs in a non-restrictive VSD with PS. So there is definitely VSD, there is definitely PS, but it is producing bidirectional. Hoffman, again, I know it seems to be a favorite topic, but then RV pressure is higher than LV, which is possible just like this, but typically it does not have a right to, left to right shunt. It is only right to left. It's like a classical TOF with RV failure with RV pressure. So since there is bidirectional shunt, there is a non-restrictive VSD. There is also PS here. So this is like a TOF physiology, but there is some sort of bidirectional shunt. I think we'll take the last question now.
Right,
and we'll stop at this. Okay. The last one, truly last. And we'll stop with this.
Sure, sir.
Yes, that would be 9:30. Any answers?
Not yet, sir, but I think we'll be getting some responses in a couple of seconds.
Yes, and we'll stop at that.
Yes, sir. So it is RSOV to RA.
RSOV to RA. Yes, I think it's fantastic. Most of you got it right. So what we have is a significant step up at RA, and the same thing is maintained. And if you look at systemically, it is fine. You look at the pressure, RA pressure is high, some pH is present, and the diastolic pressure of both iota and PA are very low. So this is a case of step up in RA with a low diastolic pressure, definitely RSOV to RA. Torrential shunt, as I mentioned, invariably there is a pH in this condition along with torrential shunt, and the RA pressure is higher than it. Typically the problem is, in this case, the murmur comes best on the right side. You will get a RVS3, REMDM, and in JVP, in this case, actually A looks more prominent, but typically V is prominent because the systolic flow is more. That's what you find in RSOV to RA. Okay. So with this, we'll stop today's class. Next class, we are going to look at the waveforms, and the class will be shorter. I'm going to show some of these cath examples, maybe 3-4, and then we will do the this one. I'll show you more examples of just the tracing. So cath is numbers, which we discussed. It's calculation, which you know, tracings, which we have, which we'll do the next class, and angio will do the class after that. Okay. With this, we'll stop this, and next class will be next Friday at 7 o'clock. The link will be sent to you by GE people. Okay.
Sure, sir. Sure. And I think, sir, with this, we have come to the end of today's session. And on behalf of GE Healthcare, we once again would like to thank you, Dr. Ranjan Shetty, for your excellent presentation and also for patiently addressing almost all the questions and also giving clarification after each and every question that you asked to the audience. We would also like to thank each one of you who joined us today for this webinar, for your patient listening and very, very active participation. Just a reminder, before you log off, you need to complete the survey which you see on your screen to provide us with your valuable feedback related to today's session. And before we formally close this session, any final closing remarks from you, Dr. Ranjan Shetty?
No, I want to thank GE for making it possible and sending it. Also thank Dr. Rocky for he's done a lot of work to prepare all these slides, and that's it. We'll meet next Friday at 7 o'clock. Okay.
Sure, sir. Sure. And once again, sir, thank you so much. Thanks to everyone. Goodbye. Take care and stay safe. Thank you.
Bye.
And because of a lot of research done, then we know we have been able to understand a lot about SARS-CoV-2. So I talked about ACE2 receptors, but there is another receptor or another protein that's expressed on the human cell, which is called TMPRSS2.